Good evening. My name is Thomas Hadjistavropoulos. I'm the director of the Center on Aging and Health at the University of Regina. We are on Treaty 4 territory. These are the ancestral territories of the Nehiawak, Anishinaabeg, Nakota, Lakota, and Dakota people, and the traditional homeland of the Métis Nation. I'm making this acknowledgement here today very seriously, not offhandedly, as a small step toward improving relations among nations. This is one of the second chances tonight. I believe in second chances, and it is a second chance because we had originally scheduled that talk, today's talk, for the spring of, the March of 2020, I think. And then everything got shut down, but here we are because of second chances. So it gives me a special pleasure to welcome you today, and thank you for coming. And I'm going to introduce you to our speaker today, Dr. Manuel Montero-Odasso, who is a professor of medicine and epidemiology at Western University in London, Ontario. Western University was called the University of Western Ontario, which actually made sense. Now they call it Western University, and I bet if you're living in Europe, you'd think that Western University is in BC. But it's not in BC, it's in Ontario. It's actually Eastern. Maybe you should call it Eastern University. Anyway, so Dr. Montero-Odasso is a geriatrician, but he's also an epidemiologist, and he has a PhD in epidemiology, which was done with combined work between Harvard University and the University of Buenos Aires. He is a very distinguished researcher in the area of geriatrics and epidemiology, with a focus on falls and also dementia prevention. He has acquired several $1 million of continuous funding over the years from the Canadian Institutes of Health Research and other sources. He has over 150 publications in this area. So please welcome Dr. Montero-Odasso. He will speak for about 45 minutes, and then we'll take questions for about 15 minutes. If you have questions after his talk, please stand by that mic, and then we'll take questions in order of first come, first served. So thank you very much again, and Dr. Manuel Montero-Odasso, thank you so much.
Thank you, Thomas, for the kind introduction. I'm delighted to be here in Regina the first time as discussion. And thank you everyone for coming. I know it's a little late, 8:30, but thank you for coming to the lecture. Again, today we're going to try to chat a little bit about dementia. What is dementia? How we prevent dementia? How we treat dementia? So, I don't have any important disclosures to provide, except I would like to acknowledge all the institutes that support my research and pay the bill for the studies. So, as you may know, dementia itself is not a disease. It's a syndrome which is characterized by cognitive problems, cognitive impairment that affect your daily living. Mainly, you may have memory problems, executive function problems, and because of those problems, you cannot perform activities daily. You cannot manage your finances, or you forget how to learn your car, you forget how to walk. That's dementia. The most frequent cause of dementia is Alzheimer's disease, which is a pathology that affects your brain and generates neurodegeneration. But also there is vascular changes in the brain, and you can see here in this picture how it looks a coronal cut on our brain, where you see very swollen, while you have Alzheimer's disease, is shrinking because some neurons are dying. And that's because in the neurodegeneration, you have some problems in the misfolding of proteins, particularly two proteins, beta-amyloid and tau protein. And the accumulation of protein generates toxicity to the neurons and the neuron die. Unfortunately, medications that were created or experimented in order to cure this disease, that we call modifying disease therapy, are still in research. There is not any medication that works for dementia. As a geriatrician, which is a doctor that sees people over 65, if we think what makes a person to look old, well, in general, two things come to my mind. One is slow mobility, what we call slow, but also mental slowing. Our processing speed, our memory is not as good as when we're younger. And sometimes slow move, like our mood is going down. The World Organization established this decade as the healthy aging decade. And in the healthy aging, they define that healthy aging is when you are able to perform all the activities they live in, because you have a very good intrinsic capacity, and we'll take what is that, and also because you interact with your environment. Basically, the intrinsic capacity means you are physically fit to do things, and you're mentally fit to do things, and you have very good social interaction, very good mood. And also, the environment, the existing world around you, is friendly for you in what you can relate. Interestingly, two main determinants of the intrinsic capacity are cognition and locomotion. Basically, memory, problem solving, and gait are part of this. I'm not saying this because as a geriatrician, I can see that when we become older, our cognition starts to decline, but also our mobility starts to decline. And it's not uncommon that both problems concur. If you go to a nursing home, the majority of the people that need to be in a nursing home is because they have mobility problems or cognitive problems. And most of them, they have both problems. So those are essential problems that come in with the aging process. In fact, in the past, all the time physicians or clinicians who visit patients, we knew that problems in your mobility and cognitive stability that will become early when you're in your 50s and 60s are going to predict fossa fracture. And the same cognitive impairments, subtle cognitive impairments, may predict dementia. We have some intermediate states, like your gait speed is going down, or you may have some condition that we call MCI, or mild cognitive impairment. Interestingly, those pathways were treated and studied independently. Those clinicians taking mobility or your rehabilitation perhaps never ask about your cognition. And those clinicians taking about your cognition perhaps never speak about your mobility. Fortunately, this has been changed in the last few years. And there's a emerging view. So clinicians that will see all the levels of 80s, we do know that it's not common when I have a patient with fossa fracture coming to the hospital, I make the diagnosis of cognitive dementia. And vice versa, when I have someone with severe dementia, they may have history of fossa fracture. So this relationship is very well established. The things that are really new is that some mobility problems, like slowing gait, may predict dementia. So we do know that some subtle motor changes in your 50s and 60s may be speaking about problems in areas of your brain that relate to dementia. And interestingly, some problems in your cognition related to processing speed or executive function may predict that you don't navigate very well, you may not avoid obstacles very well, and very fossa fracture. So there is a clear interaction with all those factors, and that's the relationship how those problems occur and commit. So, after this introduction, I want to tell you about this mind and body connection, cognition and brain connection. So, why are we discussing today whether 30 or 40% of dementias can be prevented? Well, first, because as I said before, all medications and drug treatment for dementia have been tested have failed. The The last medication approved in Canada for dementia has been Dementias in 2004. So almost 20 years without any medication approved in Canada to treat dementia. Also because we thought 30 years ago, okay, the accumulation of the beta-amyloid and the tau protein is the explanation of Alzheimer's dementia. Today we know that unfortunately it's not so simple. The accumulation of beta-amyloid of that misfolding protein in your brain doesn't explain all the variability we see in people with dementia.
And there is new studies showing that some lifestyle modifications may reduce dementia incidence, so we have less cases of dementia in those populations that made some changes in the lifestyle. So today, there is a shift for dementia management. Today, treatment is prevention. However, do we really know how we can prevent dementia? Are there any problems with all this encouraging, ideas, data, evidence? I'm going to try to review that with you guys and show some of our results we have done here in Canada in my research. As you may know, Alzheimer's disease is the most common cause of dementia. It's the disease that creates or causes 90% of dementia cases. Interestingly, something we do know, that it seems the association between the accumulation of beta-amyloid and tau and the impeding cognitive decline lessens with age. What do you mean of that? You can have your brain plenty of amyloid, which is those red areas in this SPECT scan, and you may have severe dementia, like this lady, 85 years old, has so severe dementia she doesn't remember how to walk, and she's wheelchair-bound, living in a nursing home. But you can have the same SPECT scan, the same amount of amyloid in your brain, and having a very functional life. So that is showing that amyloid is important, but it's not destiny. And I would like to pause 1 second about this. We're telling here the association between the accumulation of beta-amyloid in the brain and the clinical cognitive decline lessens with age. Meaning, if you are in your 50s and you have the early form of dementia in where your brain is plenty of amyloid, probably you will have cognitive impairment and go into dementia. But you are over 75 or 80s, your brain plenty of amyloid not necessarily will mean you will have dementia. And that's a huge, important thing. And I want to stress this, because this explains a lot of clinical variability we see in our patients. And when this started? Well, this started 20 or 30 years ago with a study that was called the NAN study. That was the cover of the Time magazine in 2001. The NAN study, which official name is the Religious Order Study and the Memory and Aging Project for Rush Medical Center in Chicago, was a study in where David Bennett and all the researchers went to convents in the US, to convents and to church. And they speak with nuns and priests. They say, would you mind to every year we provide to you some cognitive testing, and you keep a diary about your activities of living, about your memory. And when you pass away, you donate your body and your brain for an autopsy. So we look into your brain. And they say yes. So in this study, they were able to recruit more than 1,000 priests and nuns without dementia at that moment, without frailty. They were all cognitively healthy. The mean age at that moment was 70 years old, 75 years old, with high education, 18 years education, and they followed them up to 22 years. And they found that those that have Alzheimer's pathology, that was 65, only 6% that have pure amyloid, those that went into dementia. They have, the rest of the people, they have vascular changes, microbleeds, accumulation of amyloid angiopathy. They have accumulation of Lewy bodies. So they have up to 9 different pathologies, not pure amyloid, like Alzheimer's disease was described. And that was a very important game changer, because since then, other studies replicate that. Those patients that have clinical dementia, they don't have only amyloid. They have other things there, mainly vascular changes. And importantly, they have accumulation of tau. So amyloid per se, and I'm saying that because a lot of medications right now are coming to treat amyloid, right, does not predict cognitive decline. And they found up to 9 pathologies. So David Bennett, that was the principal investigator of this study, he published this paper in JAD, Journal of Medicine, in 2018, and he was posing a rhetoric question. We know that these 9 common pathologies in those people that go to dementia, depending and vary according to patients. So should we develop a biomarker to detect each pathology, to detect, the Lewy body, the microbleed, the beta amyloid? Should we make a medication for each pathology? So potentially we have a cocktail of 9 medications to treat those with dementia? And he said, well, that could result in multiple cocktail of medications that we need to give for a long period of time in people that are over the 70s, that the kidneys and the livers may not metabolize very well those medications. So in alternative ways, why would not study those people that have a lot of amyloid and never go to dementia? Those that have better brain reserve. So let's try to understand the resilience, the organ reserve. And interestingly, in the road to dementia, having in this graph changes in some biomarkers and time, in where we believe that before having dementia, you may have mild cognitive impairment, and before being mild cognitive impairment, you have cognitive normal. The thing we do know is that before having the cognitive changes, we have a lot of pathology, very, very varied pathology, which means that dementia is multifactorial. That's a key concept I would like to transmit today. Dementia, clinical dementia, is not only the accumulation of beta amyloid, it's multifactorial. Which is the context of all this? Well, there is a new body of research using observational epidemiological studies that support this, that multipathology is a cause of dementia. There is one study, the FINGER trial, that will show results that create a movement they call Wild World FINGER, which is about multi-domain life interventions. And there is some organizations like the WHO, which is the World Health Organization, the Academy, the American Academy of Medicine, and the Lancet Commission reports that also address those issues. A seminal study had been the Lancet Commission report that was published by Jill Livingstone in 2017 and an updated version in 2020. And that Lancet Commission report postulates that there are up to 12 potential modifiable risk factors in large cohort studies that were associated with the developing dementia. And the list is there. Diabetes, hypertension, obesity, physical inactivity, smoking, low education, hearing and vision impairment, air pollution, drinking a lot of alcohol, traumatic brain injury, and depression. And using sophisticated models of statistics, they found that removing those factors potentially can prevent dementia. And those studies have been replicated in other countries like China, India, even America. Not yet in Canada. But interesting, this Lancet Commission report has been so game changer that the UK, the National Health Service, established a national dementia strategy based on this Lancet report that was led by Jill Livingstone. And those are the graphs Dr. Livingston used in her Lancet report. But the main result is perhaps we cannot cure dementia. We remove those factors or we attenuate those factors. We can delay the advance of dementia. If we can delay dementia 1 year, we can reduce the incidence by 10%. If we delay it by 5 years, we can reduce the incidence by 50%. You can imagine at populational level, as a public health measure, the important implication of this, particularly also for the healthcare system. My student, Surim Som, she tried to replicate those approaches using data from Canada. And there is a huge Canadian study, perhaps you're aware of, which is the Canadian Longitudinal Study of Aging, that followed 50,000 people over 45 for several years. And there is part of those people, half of them, 28,000, they have a very deep neuropsychological assessment, risk factor assessment, and also we look for the incidence of dementia in those. And she found, using this population attributable risk formula, that's the same that we use in the Lancet report, that when we compare data from Canada with the Lancet report, we found that hearing loss and hypertension are also important, like in the Lancet report. But interestingly, we found that depression is more important, social isolation, physical inactivity. Physical inactivity seems a very important risk factor in Canada for dementia when we compare with the Lancet report, most basically in European countries. And also, we went further. The Lancet report didn't evaluate sleep disturbances. We found that sleep disturbances and obesity may explain up to 30% of the cases of dementia in Canada using this approach. But this is associations, right? Associations from, I would say, observational studies, in where we believe because dementia, if we remove the factor, we will prevent. The thing we want to see is to test this in an experiment. And the experiment in humans is called randomized controlled trial, in where you put half of the people doing a treatment, half of the people getting no treatment or placebo. And that trial has been the trial that was published in Lancet 2015, which is a 2-year trial in where they tried to do this multi-domain lifestyle intervention to combat obesity, to combat physical inactivity, to combat a poor diet, to combat a poor sleep, and so on, compare with just regular advice in people over 75 at risk of dementia. So in the MCI spectrum, the mild cognitive impairment spectrum. And they were able to recruit 1,260 people, and it was difficult to recruit people over 75, so they did a protocol amendment and they recruited people from 60 to 77. And they found the following. They found that those people receiving all these intensive interventions, they improve cognition in a composite score much better than those receiving just regular medical advice. So the control group improved, but this improved much better. And that difference was significant under a statistical point of view. In fact, in the cognitive scoring, they improved 25%, which is the same improvement you may get when you get dementia with some medication like AGSF for dementia. So that was a very important trial, a game changer. And when they analyzed which are the cognitive domains that improve with just lifestyle changes for 2 years, they improved executive function, so the capability to pay attention, switch attention, and planning and take decisions. They improved the processing speed, so to be fast doing things. And memory related to short-term memory and complex tasks. And that was quite interesting. But that's just one trial. What about other trials that perhaps didn't get the news because they were negative or they were publication bias? So I have the opportunity to review those trials because in the Canadian Conference on Dementia in 2019, I was invited by the director of the Canadian Consortium on Dementia, Dr. Cherko. He said, Manuel, we need someone to try to critique the Lancet report from Dr. Livingstone, and nobody wants to critique the report. I said, well, I don't want to critique either because I believe this is correct. No, we need to do the debate, we're going to do the debate. Okay, that gave me the opportunity to review the evidence. And we did a debate against Jill Livingstone in Quebec City. It was a very important conference that attended like 3,000 people. And later we published that debate. So we argue cases against and in favor of this life intervention to prevent dementia. And this is open access. You can access Googling my name and those words, and you find the paper to read. But basically, the main problem with the Lancet report is this population attributed risk relationship assumes there is a cause between the problem we're tackling and dementia. And that's very difficult to prove. And the other problem is when you go to analyze the data of the finger trial, although it was statistically significant, something we teach in epidemiology, the p-value is not so important because if you have enough number, you will obtain p-values with small changes. The most important thing is something we call the effect size, which is the magnitude of that change. And unfortunately, the effect size was very small, was 0.13. So it was like around a 13% improvement. So there are some limitations in the finger trials, despite it was statistically significant. The effect size was very, very small. Interestingly, finger trial was the only positive trial, and I don't want to go into those trials, but when we do exploratory analysis in the MAP trial that was negative to prevent dementia, the PREDIVA trial that was negative, or the look ahead, those trials also tried some combination lifestyle interventions, diet, and exercise were negative. Again, finger was the only positive. When we got in subgroups that have MCI or have positive risk factors, the results were significant. Which is interesting because this underscores the role of precision medicine, saying, okay, the studies are negative, but if you look in those at higher risk, the results are positive. It's like a secondary analysis. So the main criticism to this approach, okay, let's do lifestyle intervention to prevent dementia, is that the level of evidence for the research is modest. It's positive, but it's modest. And also that the relationship between risk factors and population attributed factors in the Lancet report is assuming there is a link with cost. We don't know that yet. And also how I apply my population attributed risk, my patient in my clinic in front of me. Very complicated. In favor is, well, we went to the negative studies, and when we do subgroup analysis, those at higher risk, they delay dementia, they improve cognition. So it seems there is a signal there, which highlight we need to personalize our treatments. We need to know our patients. Importantly, those strategies we're talking about, combating obesity, improving vascular risk factors, having a better sleep, a better diet, increasing physical activity, we do know have an important effect in cardiovascular medicine, in mood, in depression, even in cancer. There is evidence about cancer. So those strategies we should recommend for other diseases too. And more importantly, those strategies are relatively inexpensive with few adverse events. It's not like a medication that will cost more or have more adverse events. And at populational level, not in patient, but at populational level, even a small reduction in dementia incidence can improve the finances of our Canadian health system because we delay the progress of dementia. What about our research? Okay, let's try to do this in Canada. Let's try to use these interventions, some of them apply and people at risk. And there is this movement that started with the finger trial, and Dr. Kipibelto, who was the leader, came to Canada with us. And in Canada, we started something we call the Can Thumbs Up, the Canadian platform to prevent dementia. And other studies following the finger model have done in US, Mexico, UK, Europe, Asia, and also Latin America. In the Canadian consortium, I'm leading a group of scientists across Canada, and with those scientists, we wanted to test those interventions in a clinical trial across 5 cities. And that trial involves exercises, cognitive training, and vitamin D. I will tell you why. Why exercise? Well, it seems exercise is medicine. This picture shows the brain flow after sitting and how it changed after 20 minutes of walk. So there's no any doubt that physical activity of walking increases the blood flow of your brain. Also, as we discussed before in our meeting with attendees to this talk, the brain is the best customer of our heart because it may weigh between 1.5 and 2 kilos, depends on your weight, but it's taking 20% of the energy of your body, and all the blood flow is going to the brain. And the old motto, mens sana in corpore sano, from the Romans and the Greeks, is true. We do know that when you have a healthy body, provides not only blood flow, but also growth factors. We discussed before that our muscles, that in the past, we believed that skeletal muscle was only important for movement and locomotion. The real endocrine organs that when you do exercise release cytokines, brain factors to the blood acting in your brain. And we know that also those exercises are important to reduce chronic comorbidities of factors like diabetes, hypertension, that have a negative effect in the brain. But which is the good exercise for your brain? Well, in general, we have two types of exercise, right? Or several types, but the 2 types that are explored more importantly for brain health have been aerobic training, like running, walking, swimming, and resistance training, which is lifting weights. There is other kind of exercises, like anaerobic training, balance, yoga, that also have been explored. And the most important relationship between exercise and brain health is coming for aerobic training and resistance training. If you need to do one exercise for your brain, aerobic training is most important. But it seems the combination of resistance training is better than the aerobic training alone. Those exercises are good for other reasons, may reduce disability, may reduce your falls. Unfortunately, there is no strong evidence that improves your brain health. In fact, you know, resistance training is becoming as a very important exercise to improve your brain health. And the New Yorker make a joke about that, right? That sometimes people doing resistance training just to improve brain health. Interesting, which are the domains in cognition that improve with exercise? Well, mainly executive function, right? Processing speed, planning, dual tasking. Although the memory that depends on the hippocampus, it seems also improved with aerobic and resistance training exercises, which are both domains strongly associated with dementia. So we want to improve those domains. For example, early studies, even in 2004, showed that just aerobic exercises improve not only the blood flow, but also performance in cognition. And this, you Google my name, you can find that there is several hypotheses while interventions may improve brain health. And that came to me to the synergic trial. In this trial that we've done across Canada, we wanted to test if the combination of these 4 potential treatments, aerobic exercise, resistance training, cognitive training, I will tell you what is that, and vitamin D, may have an effect to delay dementia. And we wanted to include 200 people with mild cognitive impairment, so cognitive that is not good enough to be normal, but it's not as bad to be dementia, with an age of 60 to 85, and we wanted to provide this for 6 months. And the primary outcome was a cognitive composite that we use to diagnose dementia, which is the ADAS-Cog13. And we have several secondary outcomes for exploratory analysis. And we called that trial synergic trial because we want to synchronize remedies, and exercise to improve cognition, but also mobility and gait. And those are pictures of our participants that are on the website and doing some exercises, and here with some tablets. In this case, we use iPads to do the cognitive training. And we have a complex design. Basically, we call factorial or fractional factorial design, in where some participants receive the 3 interventions, the combined aerobic exercise resistance training, plus the cognitive training, plus vitamin D, while one group received all placebo or sham intervention. We wanted to give an exercise, but we want to give an exercise that was shown no improved cognition. So we get balance and toning exercise. We did some cognitive control training, was no cognitive training, was just doing puzzles or exploring things in the iPad, and placebo vitamin D. And in the middle, we tried to combine the real intervention with the sham intervention, so we can see the effect of the individual interventions. And the goal was to evaluate if this combination of exercise, with or without cognitive training vitamin D, improve cognition and delay dementia. The cognitive training was the NeuroPeak cognitive training that was developed by Karen Lee from Concordia University and Louis Verret from Université de Montréal, part of my team, and was tablet-based. We used the iPad, as I said, was multimodal in where we tried to improve executive function, dual tasking, but also memory. And we did that training before each physical exercise that was coached with a trainer. And the cognitive training was done in the cloud, meaning that you were doing better in the cognitive training. The cognitive training was more complex. You doing worse in the cognitive training was less complex. And basically, in the beginning, you need to detect when a celestial body appears or an animal appears. You need to tap on that. But later, you need to remember which animal or what celestial body appeared. And you're doing better, become more complex and more complex. So at the end of the intervention, after 6 months, there were no 2 participants having the same cognitive training, because you were doing worse, become less complex, right? So it was adaptative. And the physical exercise was the combination of both aerobic and resistance training for 1 hour, that we call it the Synex COG, Synergic Cognitive Training Exercise, that was personalized for each participant and very intense and personalized. And that was, as I said, concurrent after the cognitive training. And we gave vitamin D to everyone. Basically, they come 3 times a week to our academic gym in London, Ontario, when Waterloo, when British Columbia, Vancouver, or in Alberta, when Montreal, they were the sites when we did the trial. And when they were in the gym, we give the vitamin D in a blister, just to be sure they have very good adherence. The dose of vitamin D was 30,000 units per week, which was an equivalent, I will say, 10,000 units per day, the equivalent of 4,000, 2,000 units per day, right? This is the flow chart. So, as you said, we wanted to include 200 people, but unfortunately COVID hit, so we include only 175. This is the distribution, which is very complex, but just to show you there was similar distribution in each arm of the trial. We examine, I will present the data of the result of each arm, but also the beauty about fractional factorial design, they allow us to collapse those groups with those groups, because those groups are receiving the same kind of exercise, you can see. The only difference is the vitamin D. And those groups are receiving just exercises plus control cognition of vitamin D. And we found the following. Look at this. Those here are changes in cognition. Group number 1, they have the 3 interventions. They improve cognition significantly, 2.5 points. Those that receive the exercise cognition and placebo vitamin D, they improve similarly. So when we look for the effect of vitamin D here, there was no effect, no interaction. While those receiving exercise with placebo cognitive training, those receiving vitamin D, they improve less. So exercise was good, but not as good as the combination of exercise with cognitive training. And the placebo group that received balance and toning, cognitive control, and placebo, they got worse a little bit. Because we couldn't find the effect of vitamin D, statistically, this allowed me to pool the groups, to do collapsing. So join this group plus this group versus this, and you can see here. So control group had a slight decline, while the combination of physical exercise with cognitive training and vitamin D had the most important improvement, which is negative in the ADAS-Cog, right? Lower, 0 ADAS-Cog is normal, 20 ADAS-Cog is abnormal. That was quite interesting because we found a change, almost 2.5 points in the ADAS-Cog, and the magic number to get a medication approved by Health Canada for dementia is 3, so we're very close to 3. But the effect size was very important, 0.7, independently that we couldn't reach the 200 people, we reached only 175. Because when COVID hit, we couldn't keep recruiting or doing interventions to the participants. And those changes were statistical significance, very, very significant. But as I said before, we are not very, I would say, excited about the p-value. We're very excited about the effect size, 0.7, very high. And when we look which are the domains were driven this improvement in cognition, were improvements in word recognition, orientation, but memory, word recall and delayed word recall. So it seems these exercises improve orientation and memory. And the graph before, why that can be improved. So what are the limitations of this trial? Well, there's something negative here, limitation, that we couldn't reach the 200 due to COVID pandemic restriction. Although the number was good enough to detect changes. The dropout was high, 18%. We calculated 10% dropout. But 50% was related to COVID. People couldn't go to the sessions. And the problem, vitamin D didn't show any effect, but all our participants in the plasma had high level of vitamin D because everyone was taking vitamin D before coming to the trial. So perhaps if we have people with vitamin D deficiency, the result can be different, but that's a limitation. But we found that exercise by cognitive training showed a synergism and improvement, and we found that was feasible to do in other people with MCI. The changes were with a medium-large effect size close to the 3-point range, and when we present this to the Alzheimer International Conference in San Diego last year, Ronald Peterson, who created this entity about MCI, was very excited about our results. And the other conclusion is vitamin D, it seems, doesn't have an effect. So we're very excited about the results. And these are being reviewed right now in a larger journal, which is the JAMA, Journal American Medical Association, so we hope to get published soon. But what's the future about all this? And we can go to questions later on. It seems the evidence is showing multi-domain intervention may work, particularly if you personalize, you got people at risk. Our study is showing that you go to people with MCI, the higher risk, the combination works. And doing changes similar to medication we use in dementia. I think the future is perhaps how we can do this at home, right? Using wearables or digital interventions. It seems exercise is key. Exercise is very important. More study about dementia, it seems so far, we need to keep doing exercise. The other problem is how we do this, because behavioral changes are very difficult to obtain. So coaching, we need effective coaching, right? Something we learned when we got COVID pandemic is we migrate those participants that were doing the exercise and the cognitive training at home, and we provide the iPads at home, and we did with Zoom. We didn't include those participants in our analysis because it's a different intervention, but that showed us we were able to do it at home. We were able to deliver those interventions at home. So I think the way we do the future is we create the future. We need to create the future in that way. now we got funded by the Western Family Foundation to do the Synergic 2 trial that we just launched a few days ago across Canada. And in this Synergic 2 trial, we're using a digital platform in where we communicate with our participants of the MCI, and in where we personalize the menu for them based on the risk factors. And we coach them, and we do a mailing for elastic band, resistant bands, and things to do the exercise. We provide the cognitive training with the iPad. We provide recommendations about diet, about the sleep. And we coach them every 2 weeks. 2 weeks they're doing alone, for 2 weeks they're doing with our coaches via Zoom, and they can see the progresses. And we have a control group that receive only educational programs, how to prevent dementia. And this we call the Synergic 2 trial, in where it's more simple here. It's only 2 groups. Those receiving the personal multi-domain intervention via Zoom with effective coaching versus those receiving an educational online program that brings health support. And we aim to recruit 550 people across Canada. Those are examples of the details of the interventions. But just to finish, and I think we're in good time, what are the messages I would like to transmit with my talk today with you? First, concept. Cognitive impairment with aging, dementia, even Alzheimer's disease dementia are multifactorial with several potential modifier risk factors. It's just not the accumulation of beta amyloid. Importantly, one of those risk factors, it seems, are vascular risk factors, hypertension, diabetes, obesity, that are suitable of changes with lifestyle interventions, increasing physical activity, doing better diet, and so on. Probably because it's multifactorial, interventions that target several risk factors or several mechanisms are the best. And probably that's perhaps the reason why exercise are so good. Because exercise improves your blood pressure. Exercise diminishes your level of obesity. Exercise releases cytokines to the blood. Exercise may improve your mood. So exercises, particularly the combination of resistance training and aerobic exercises, have several potential mechanisms. For sure, we need more randomized controlled trials, but so far we have very encouraging results, particularly highlighting personalized medicine. So when you go to general populations, results small effect size, like the finger trial. When you go to specific high-risk population or those with risk factors, it seems the effect size better, as we saw in the Synergic trial. The other concept is perhaps, based on the Lancet report, we need a life course approach. Perhaps we need to start doing this in our 40s, in our 50s, right? Because it may have an effect when we reach our 60s and 70s. These interventions may vary across the countries. The work of Surin, some of my PhD students showed that compared with the Lancet report, it seems in Canada we have more incidence of physical inactivity and obesity than in Europe. So perhaps we need to target more of those factors rather than the others, right? And just thank you to all the members of my lab, all the agencies that pay the bill of my research, and I'm open for every question you may have. Thank you very much.
Thank you so much. I mean, the logistics of carrying a project like that are just incredible. It may sound easy, but to run a multi-site trial of this magnitude, it's just incredible. So congratulations for that.